Good afternoon. My name is Chung. I'm Assistant Professor at Baylor College of Medicine in the Division of Vascular Surgery and Endovascular Therapy. I wanted to thank the program committee for the privilege of the virtual podium this afternoon. Today I'm going to be talking to you about aspiration mechanical thrombectomy of a tumor embolism in the pulmonary arterial tree. So this is a case of a 66-year-old gentleman who had a large locally advanced renal cell carcinoma. This is shown by the yellow arrow here. This is the renal cell carcinoma invading into the IVC here and with a significant amount of tumor burden within the IVC. This patient was evaluated by our urologic surgical colleagues, and they evaluated the mass and deemed that it was resectable. They planned a right radical nephrectomy with IVC tumor thrombectomy. The operation was performed, however, unfortunately, it was complicated by tumor embolization, which was confirmed by intraoperative TEE. The patient immediately developed cardiovascular collapse and required ECMO support via femoral, venous, and arterial ECMO. The patient was then transferred to the ICU in critical condition, which is when our service was called to evaluate the patient. This is when we obtained a CTA of the pulmonary arterial tree, and this shows evidence of the pulmonary embolus that is lodged largely within the right PA, and you can see this, it's in the apical branch and the middle lobar branch, as well as some within the left main pulmonary artery as well. So our clinical dilemma was that the patient was on full anticoagulation and on an ECMO circuit. The patient also had a recent operation which precluded the use of systemic or catheter-directed thrombolysis. The patient was in severe right heart strain, however, that precluded weaning of the ECMO, so we were stuck. Moreover, we suspected strongly that the thrombus itself was not simply clot, but tumor, and this would be unamenable to more traditional methods of chemical thrombectomy. So we began the procedure by performing a pulmonary angiogram. And what I like to use here is the Rollman angled catheter. This, from the femoral position, slips right into the PA for me. And this was our initial pulmonary arteriogram. And what you can see here is confirmation of what we found on the CTA. We found that there was a tumor here. You can see this by the haziness and decreased flow to the middle lobar and superior lobar branches on the right. On the left, there is some haziness here, but not as significant. We decided to use the pulmonary penumbra catheter to aspirate the thrombus. This is before the Lightning was invented and available within our hospital. And so we used this to perform directed suction thrombectomy and of the segmental branches. This is what we were able to remove from the canister afterwards. And you can see this is tumor thrombus. This does not look like normal clot. And indeed, when we sent this to histology, we found that this was indeed right renal cell carcinoma. This is our post-procedure pulmonary angiogram, and you can see now that we've removed all this haziness, all the thrombus here. We've restored patency here to the right middle lobar artery and the right superior apical branch. As well, as you remember from the prior pulmonary angiogram, these inferior branches did not fill as well. After we passed the penumbra here, we were able to restore patency to these vessels as well. Afterwards, all wires and catheters were removed. The patient tolerated the procedure very well, and the patient immediately improved in their hemodynamics. They were able to wean the vasopressor support as well as the ECMO support. ECMO was removed on postoperative day 1. Our procedure itself had only an EBL of 400 cc's. So after the decannulation from the ECMO on postoperative day 1, the patient was extubated on postoperative day 3 and discharged home on postoperative day 7. Today is actually 2 years of follow-up, and the patient continues to remain cancer-free without any evidence of pulmonary hypertension. So I wanted to show you this case because I think it exhibits the potential of aspiration thrombectomy to be used even in situations where thrombus is not present, but instead actually solid matter, solid chunks of debris. This is a little study that shows some of the early experience with aspiration thrombectomy in high risk and intermediate risk pulmonary embolism. This is a series of 14 patients, and what they were able to do is show that you can get 9 patients with complete clearance and 5 with partial clearance with One mortality, though this was somebody that had been already coded for 24 hours prior to presentation. And so this is unlikely to be due to the procedure itself. This simply shows the proof of principle that pulmonary aspiration works. So to conclude, this is feasible and safe. It can provide immediate restoration of the normal pulmonary arterial flow without thrombolytics. This is still very early in the experience. In fact, this is the only case I know of that's reported in the literature that has aspiration of an actual tumor thrombus from the pulmonary artery. So this will require further evaluation, comparative effectiveness studies for long-term results and efficacy. Thank you very much for your kind attention, and thank you again to the program committee for the privilege of the virtual podium here.